Hello, welcome to Chapter 17, Renal Disorders from your Peds class. This isn't a really long chapter, but it does have a lot of information in it. We're going to talk about the basic pathophys of your kidneys, normal and abnormal values, all kinds of important stuff in this chapter. So when we talk about the anatomy and physiology, the two kidneys are in the retroperitoneal space, slightly above the umbilicus. That's why when you do that assessment, you're checking the flank area. The renal arteries supply the kidneys with blood. The right kidney is a little bit lower than the left. And your kidneys are made up of over 1 million nephrons. The kidney contains a glomerulus, a tubule, and a collecting duct. And your nephrons are what filters out the harmful products from the blood. And each renal pelvis extends to form a ureter, and the ureter drains down into the urinary bladder. The urinary bladder is what collects the urine, which is excreted through the urethra. The normal urethra has one-way valves allowing drainage and prevention of the retrograde reflux of urine. And remember that the kidney function is not completely mature until about 2 years of age. So when you're assessing for renal disorders, you really do need to, again, do a very comprehensive family history, a history of the child. Did they meet their developmental milestones? How's their diet history? You need to complete a physical exam. Do they have any associated symptoms? Anything that makes it better? Have they been ill? Especially with viral or bacterial infections. What's their medical history? Have they been in the hospital? Have they had any history of Foley catheters or even straight calves? Have they been on any recent medications? Especially make sure and ask if they've been on any herbs or over the counter. Have they been on any kind of medicine that was nephrotoxic? And your common nephrotoxic drugs are your aminoglycosides, your amphotericin B, vancomycin, NSAIDs, heavy metals, and ACE inhibitors. And we use ACE inhibitors to treat blood pressure. Have they had any history of fractures and trauma? Do they have any osteoporosis, even as a kid, because this is common in your chronic renal diseases? Do they have a history of growth restrictions or frequent infections? And we'll talk about in a minute that growth factor and growth hormone, how that's different in renal disease. Do they have any history of urological anomalies, any history of previous surgery, any sexual activity? We do know sexual activity is a risk factor, although we're really not sure why. Family history, do they have any history of recurrent UTIs, chronic kidney disease, renal abnormalities such as vesicocultural reflux, any family history of deafness, metabolic disorders, immune disorders, kidney stones, thyroid issues, gout, family members needing dialysis, family members with growth restriction. How is the patient's protein intake? Remember, a high protein diet can worsen their renal disease. How is their fluid? And a lot of times fluid restriction is an important component of renal disorders. Poor fluid intake or dehydration can lead to acute renal failure. A ketogenic diet increases the risk for nephrolithiasis, which is kidney stones. High oxalate foods may increase the risk of nephrolithiasis. Do they have a history of failure to thrive? And many renal disorders manifest in infancy with failure to thrive. So as you're doing your physical on the child, how are they appearing? Do they look sick? Do they look toxic? Are they well appearing? How's their pulmonary system? Do they have any changes in their breath sounds, cough, shortness of breath? Do they have any tachypnea? You really do need to monitor for fluid overload that's caused by the kidneys. Any pulse ox less than 93 needs to be checked. And we have to remember, the major function of the renal system is to regulate regulate the fluid balance. Fluid accumulation from poor glomerular filtration and urinary excretion can lead to the pulmonary edema. How's their cardiac system? Kidney function its major function is to maintain fluid balance, electrolyte balance, and excrete waste products. So this definitely can affect the cardiovascular system. Decreased pulses in lower extremities can indicate blood pressure and poor perfusion. A cap refill of greater than 4 seconds indicates poor perfusion. Blood pressure. An elevated blood pressure can indicate glomerular nephritis, acute or chronic renal failure, renal artery stenosis, or dysplastic kidney. When you're taking a blood pressure, if the blood pressure is abnormal, you need to go back and relook. Is it an appropriate size cuff? Remember, if the cuff is too large, that's going to make the blood pressure lower than it actually is. If the blood pressure is too small, it's going to make it higher than it actually is. Is it placed properly on the arm? So lots of things to look at. You need to check their pulses to make sure they're not bounding, which can happen if they have fluid overload. How's their heart sounds? How's their extremity temperature? In the GI system, we know that chronic kidney disease is associated with anorexia, constipation, and failure to thrive. Do they have any palpable stool in the abdomen, which is what we see in constipation? And just for your knowledge, as we're looking at the GI system, diarrhea in an infant can be caused by urinary tract infection. Vomiting can also be a symptom of urinary tract infection. Weight loss or failure to thrive should always be investigated for any kind of a UTI or renal disease. Weight gain may reflect extracellular fluid collection and should be investigated for renal disease. Do they have abdominal pain? Do they have enlarged organs? So lots and lots of different kinds of things. Remember that pulmonary hypoplasia is a congenital disorder that occurs in association. Vater syndrome is a complex system or syndrome of multiple congenital anomalies, which does include renal. Turner syndrome is a genetic condition that also has renal implications. If it's a boy, are they circumcised? Uncircumcised males have a higher incidence of UTIs. Do they have any suprapubic tenderness? Do they have an enlarged bladder? Do they have frothy urine? And if you don't know what frothy is, that's that air bubbly. So it looks bubbly. Do they have any proteinuria, which is protein in the urine? What's their urine color? Do they have any hematuria, which is blood in the urine? And this can even look as tea colored. How's their urine flow? Do they have a poor or weak stream? How's their INO? For skin, do they have a rash? Do they have palpable purpura on the posterior surface? Do they have sticky or dry mucosal membranes? And remember, severe dehydration can lead to acute kidney injury, AKI, so you want to make sure they're not dehydrated. Neuro, do they have any hearing loss or physical ear anomalies? And the reason we look at this is because when a child is in embryo, the renal system and ear system develops at the same time. So a lot of times, if there's an anomaly of one system, you'll have a congenital anomaly of the other system. Muscular skeletal system, do they have appropriate linear growth and appropriate weight gain? Many renal disorders present with poor weight gain, growth restriction, failure to thrive. And remember, growth hormone is decreased in chronic renal diseases. Muscle cramping can indicate electrolyte disturbances such as hypokalemia, hyponatremia, and hypercalcemia. Bone pain and fractures can be caused by osteodystrophy, osteopenia of chronic renal disease, and that's due to the low calcium. And that's because of the inability of the kidney to convert vitamin D to the active form. Do they have CVA tenderness? We see CVA tenderness a lot of times in UTIs. Weakness and malaise may be secondary from anemia or chronic kidney failure. How's their lymphatic system? Edema can be caused by decreased circulating protein, which is called hypoalbuminemia. Nephrotic syndrome is characterized by proteinuria and hypoalbuminemia, resulting in edema. They may have periorbital edema, facial edema. They may have ascites, which is that fluid in the belly. They may have scrotal edema, sacral edema, and edema is always dependent. So just be aware of that. Endocrine system, you want to palpate their thyroid. Hyperthyroidism is associated with chronic kidney disease. How's their renal system? Large dysplastic kidneys can be felt at times on physical examination. Urine output, how is it? And just remember, and you do need to know this, normal urine output in kids is 2 milliliters a kilogram per hour. Teenagers, adolescents can have 0.5 to 1 milliliter per kilogram per hour. Here's our normal lab values. So a UA, urinalysis, you want to see specific gravity, 1.001 to 1.035. pH is 5 to 8.5. You should have negative protein, glucose, ketones, bilirubin, blood, nitrates, and leukocyte esterase. These should always be negative. Now, occasionally, if you get a contaminated specimen, they may have a false positive, but they should typically be negative. Complete blood cell count, remember normal white blood cell is 5 to 10,000. Red blood cell is 4.6 to 4.8. Hemoglobin, male is 13.6 to 17.5. Female is 12 to 15. Hematocrit, males is 39 to 49 and females is 35 to 45. And if you don't remember this, remember I said the hematocrit should always be about 3 times the hemoglobin. Platelet should be 150 to 350,000. Your electrolytes, sodium should be 135 to 145 milliequivalents. Potassium 3.5 to 5.0, 3.5 to 5, stay alive. Chloride 98 to 107, carbon dioxide 22 to 28, BUN 8 to 20, and creatinine 0.6 to 1.2. So when we start looking at disorders of the renal system, we do have urinary tract infections, and this can be an infectious process that involves the urethra, bladder, ureters, renal pelvis, the renal calci, the renal parenchyma, and it can be isolated or it can be the entire urinary tract system. More commonly seen in kids 2 to 6 years of old. UTIs are the most frequent site of the bacterial infection in febrile infants. E. coli is the most common cause of UTIs. And typically symptoms do not mimic the same symptoms as an adult, and they can be much more subtle and just have a fever. If left untreated, UTIs can lead to renal scarring and failure. So, typically with UTIs, you see fever above 100.9, vomiting, abdominal pain, flake pain, back pain, dysuria, frequency, urgency, hematuria, jaundice, poor oral intake, hyperthermia, hypothermia, failure to thrive, and you can have diarrhea. Diagnostic tests, you're going to do a UA, and they're typically positive for nitrates or leukocyte esterase. Urine nitrates are almost always diagnostic of a UTI if they're positive. You can do a urine microscopy, which would show bacteria and white blood cells. You can do a urine culture, and that looks at, it identifies a specific bacteria as well as the antibiotics that will treat it. One of the big things I always like to mention is babies, we used to do a urine bag culture. So the urine bag would go over their urethra, and you would just leave that bag on there and it had a sticky surface that went down over the urethra with a little sponge on it, and you would leave that until they urinate and take it off. Well, we know because that sits on there for a couple of hours typically that it's going to contaminate that bag. And because we have normal bacteria on our skin, and when that normal bacteria falls down into that bag, it's going to make it look like a false positive. They can have a renal ultrasound, a voiding cystourethrogram, and that's where they are catheterized and they run dye up through there. And so we can see the contrast shows us how they're voiding and the drainage. So your interventions, you want to make sure their circulatory status is stabilized. They may need a 20 milligram per kilogram IV fluid bolus of saline or lactated ringers. They're going to need broad spectrum IV antibiotics, which is your ceftriaxone. And if you don't know what ceftriaxone is, that's your Rocephin, and that's 50 to 75 milligrams per kilogram per day. You'll see cefotaximine, which is 100 to 200 milligrams per kilogram per day. Now, you guys don't need to know the dosages on this for the test, but you do need to know what antibiotics are typically used for broad spectrum. Any kid or baby, infant that's less than 2 months old that has a UTI does need to be worked up for sepsis. You will see a lot of these kiddos hospitalized for urinary tract infections. You want to educate caregivers on good hygiene, aseptic technique, avoid bubble baths, and I typically have them avoid baths in general, do showers. Things you can do as a nurse, remove the Foley catheter as soon as the patient doesn't need it. We need to educate caregivers on completing the full course of antibiotics, as well as the importance of follow-up testing. The patient, if they're getting a lot of urinary tract infections, especially if there's a congenital issue, they may need to be on prophylactic antibiotics. So you want to educate the caregivers on what that looks like. You want to encourage liquid intake appropriate. You want to promote regular voiding. Kids that hold their urine, especially during potty training, are increased risk for UTIs. You want to avoid any kind of perineal irritant, which is like the bubble baths, correct constipation, high fiber diet. And some of the alternative therapies, cranberry juice or orange juice, these typically make the urine more acidic, so bacteria doesn't like to thrive on those. So it's good if the kid drinks a little bit a day. We don't want to have them drink a lot because it is very high in calories. And with the obesity epidemic, we're a little bit careful on putting a bunch of calories that are drunk into the system that doesn't provide really good nutrition. One of the things I miss there is when a child is old enough to start having sexual intercourse, you want to make sure and educate them to void post-coitus. Again, because you got to think of all the extra bacteria that then is around their urethra, and so you want to void that out. Vesicultural reflux, this is a congenital anatomical abnormality. It allows a retrograde flow of urine from the bladder into the ureters and renal collecting system. It is the most common congenital anomaly affecting the urinary tract. In fact, my daughter had this. It increases the risk for UTIs and renal scarring, which can lead to end-stage renal disease. They're going to have that voiding cystogram, but their typical signs and symptoms, they have frequent UTI, suprapubic pain, urinary incontinence. It does typically run in families, but like my daughter, no one in our family had that, either on my side or her father's side. These kids have an enlarged bladder. Diagnostic, you're going to do a UA, a urine culture, post-voiding catheter to see if they're urinating out all the urine or if there's still some there. They'll have a renal ultrasound to look for hydronephrosis. They'll have the VCUG so you can grade the vesicultural reflux. They may have a DMSA scan to look for renal scarring. And your stages, remember, stage 1 is ureter only. Stage 2 is ureter pelvis calci, no dilatation, and it has a normal calciophomices. Grade 3 is a mild or moderate dilatation in tortuosity of the ureter, mild or moderate dilatation of pelvis, but no or maybe slight blunting of the phomices. Grade 4 is moderate dilatation in tortuosity. I can't speak today. Tortuosity, and grade 5 is gross dilatation in tortuosity. And you can see on that x-ray, that's actually a VCUG, and the right side, which would be the patient's left because it's backwards, the left ureter, you can see how when they inserted the dye into the bladder, see how that dye went up into the ureter all the way up into the actual kidney itself. These kids could have to have dialysis if renal failure is present. They almost always are on empiric or prophylactic antimicrobials. If they have to have surgery for those valves, then you're going to do post-op care. You're going to make sure these kiddos have strict INO. And these kids, a lot of times, if they get a UTI, are going to be on ceftriaxone or cefotaxamine, amoxicillin. Nephrolithiasis, fancy word for renal calculi, fancy word, aka kidney stone. And this is where urinary crystals form renal stones. It is steadily increasing in kids and adolescents. Obesity, increased sodium consumption, decreased water intake, and decreased calcium consumption have been proposed, but not proven. That's just what we think as contributing factors. Other metabolic diseases such as loop diuretics, which is like your Lasix, urinary tract infections or congenital anomalies increase. Vitamin D supplements, calcium supplements, vitamin C, diuretics, steroids, ceftriaxone, and some anti-epileptic medications are associated with nephrolithiasis. Children with metabolic disease or genetic or urinary tract abnormalities are at greater risk. Females are at greater risk. Usually signs and symptoms, colic type, abdominal flank or back pain. Colic means that it's comes in waves, I guess I should say. Almost like if you think about labor pain, but it's not labor, it's one-sided. You can have it on the front in your abdomen, you can have it in the back, you can have it on the side in your flank. They may have hematuria, they may have a UTI, they may be a poor feeder. They can have acute renal failure if a single kidney is obstructed. They can have nausea, vomiting. Diagnostic, you're going to do a UA, you're going to do an x-ray, an ultrasound, a CT to look for those stones. If they pass a stone, you're going to do a lab analysis. You're going to do a 24-hour urine collection. These kids need to have IV fluids at 1.5 to 2 times the normal maintenance rate. A lot of times we give them tamsulosin. And if you don't know what tamsulosin is, a lot of times that's given for men with enlarged prostates, but it actually does relax the ureters. So it does work in kidney stones as well. Pain control with narcotic and non-narcotic medicine. We actually give these people morphine, oxycodone, acetaminophen, because these are painful. You want to make sure you're doing an accurate INO. You want to monitor for urinary obstruction. If they have a stent placement, you want to assist with that. You're going to monitor for renal failure. You're going to, when they urinate, you're going to strain the urine for stone collection. You're going to check their vital signs. And remember that surgery can be open or closed, like they can do the shockwave lithotripsy, or they could do open where they go in and put the stents in. So lots of different ways to treat this. The biggest thing for you to know is understand what causes it, as well as prevention, education, and how it's treated. Next, we're going to talk about nephrotic syndrome. Goodness gracious. Okay, so nephrotic syndrome, most common kidney disease in kids, and it has massive proteinuria, hypoalbuminemia, edema, and hyperlipidemia of unknown etiology. This is where your micromolecules are filtered into the glomeruli, allowing albumin to cross the capillary wall. The loss of protein in the urine changes the oncotic pressure within the intravascular space, causing intravascular depletion of volume and extracellular edema. It's typically seen between 2 and 5 years of age. We do see different types, such as minimal change, focal segment, membrane proliferate, or it can occur after an upper respiratory tract infection, which is why it's important, again, on your history to see if they've been sick with any viral or bacterial infections. There is a great diagram in your book, and it shows how millions of tiny kidney filters leak the protein out into the urine, which causes a proteinuria. This means less protein is left in the blood, and the fluid leaks out into the blood vessels, causing edema. Remember, your edema is gravity dependent and occurs gradually. So gravity dependent, like if you think about if their legs are down, they're not propping their legs up, the edema is going to go into their legs. But if they lay flat, the edema is typically going to go into the lowest area. So it could be their abdomen, could be their head. You can often see tachycardia, oliguria, and orthostatic hypotension. Complications can be peritonitis, thromboembolism, acute kidney injury, and malnutrition. Infection is the most common complication, followed by thromboembolism. We typically use broad-spectrum antibiotics. Clinical presentation, edema. They a lot of times will have it around their eyes, their scrotum, their sacrum, ascites, and pretibial. Do they have any weight gain? Do they have decreased urine output, anorexia, easily fatigued, hypertension? And you're going to do a UA, and in the UA, you're going to see heavy proteinuria. They can have microscopic hematuria. They can have serum protein less than 2.5. On their electrolytes, they typically have hyponatremia. Their complements, C3, C4 are typically off. Urine creatinine is usually normal on the presentation. their serum cholesterol and the low density lipoprotein, which is the LDL, is increased, and your LDL is your bad cholesterol, remember. Calcium is reduced, but ionized calcium is typically normal. They have a renal ultrasound, a chest x-ray to detect pleural effusion. You're going to give them some oxygen delivery for respiratory distress, CT to look for pulmonary embolisms, ultrasound. If they have a pleural effusion, they're going to have it drained. You're going to do IV fluids at 20 milliliters per kilogram, bolus. You're going to do administration of IV diuretics for fluid overload, which is like your furosemide or Lasix. You're going to do administration of IV antibiotics for suspected infection, which is your cefotaximine. And because they are high risk for emboli, you do need to check for peritonitis, pulmonary embolisms. You're going to initiate corticosteroid therapy, which is your prednisone. And remember, anytime you get prednisone, you can have secondary complications, such as like your diabetes due to the elevated blood sugars, because corticosteroids do increase that blood sugar. They may need diuretic therapy. They may need IV albumin infusion. You want to make sure and get them a nutritional consult to correct malnutrition, as well as maintain the appropriate fluid restriction, strict monitoring of daily weights. That means same time every day in the same clothes. And actually, let me rephrase that. They should be unclothed. So first thing in the morning, have them urinate and then immediately step on that scale. Strict monitoring of I&O, monitor their abdominal girth, monitor their vital signs, encourage ambulation and physical activity to prevent stasis complications, especially when we're worried about thrombi. Anybody with shortness of breath needs to be checked immediately because of being concerned about pulmonary embolisms. You're going to go ahead and give these kids Prevnar annually for a vaccine. You're going to prevent skin breakdown. You're going to do good hand washing, limitation of sick contacts. You want to give them a TB skin test, which is your PPD. You're going to educate parents on how to take care of their kid. Urine nitrates are A, usually not, B, almost always, C, always, and D, never diagnostic of UTIs. Do you guys remember this? B, almost always. Sorry, I got to check my phone real quickly here. Okay, acute post-infectious glomerular nephritis. This is an inflammation of the glomeruli in response to an illness, most recently a strep, upper respiratory or skin infection. It's typically 10 to 14 days after the acute infection. They typically have painless hematuria. And remember, it can be tea-colored or cola-colored or bright red. They're going to have proteinuria, oliguria, hypertension, edema, anorexia, upper respiratory infection or skin infection that preceded it, arthralgias, pulmonary edema, abdominal pain, malaise, impaired renal function. You're going to check their serum urea and creatinine because it's typically elevated. Their serum protein is decreased. Their white blood cell count is elevated. Their ESR, which looks for inflammation, is elevated. Their serum C3 complement is decreased. C4 is normal to low. UA shows hematuria, proteinuria, red blood cell cast, and hyaline cast. You do want to do an anti-strepolin O, anti-DNase B to check for streptozyme results. You want to check them for anemia, hyperkalemia, and they may need a renal biopsy. You need to do a throat culture to check for strep infection. In emergent cases, they can have dialysis. We do hypertension management with nifedipine. You're going to administer sodium polytyrene sulfate for hyperkalemia. Seizure control, especially if you're worried about hypertensive encephalopathy, which you typically do with lorazepam. You typically give them antibiotics if they're in the hospital in case they do have a strep infection. You're going to give cefotaximine or cefotraxazone. You're going to do strict monitoring of vital signs, blood pressure, INO, daily weight, diuretics. And your diuretics is furosemide or Lasix. You're going to do a nutritional consult for no added salt diet and fluid requirements. You're going to assess their neurostatus. You're going to do renal replacement therapy if needed, activities as tolerated. You're going to educate caregivers how to do an appropriate blood pressure, written dietary instructions, psychosocial support, seizure precautions, hyperkalemia signs and symptoms. And then, you need to do an ECG on these patients because remember, anytime you have those electrolyte imbalances, you can have some cardiac arrhythmias. Henoch-purpura. This is a vasculitic disorder, and they typically have a tetrad of symptoms. They have the rash, the arthralgias, and the abdominal pain, and hematuria. It's self-limiting, and most kids have a full recovery. It typically follows a upper respiratory tract infection. Intussusception, which we talked about in GI, is a common emergent condition seen in these kids as a result from intestinal edema and hemorrhage. Clinical presentation, they often have colicky abdominal pain, palpable purpura in the dependent areas, non-migratory arthritis or arthralgia in the lower extremities, edema of face, lips, dorsum of hands and feet, scrotum, occult or GI bleeding, microscopic hematuria, proteinuria, anorexia, malaise, erythema nodosum. They're going to have diagnostic of CBC. They're going to do an ESR, which is most often elevated. CRP, which is your C-reactive protein, is elevated. Coax studies are often normal. They're going to have an elevated serum creatinine, a UA that shows proteinuria and hematuria. Stool occult blood is positive. You're going to do an abdominal ultrasound to evaluate for intussusception. They're going to have a skin biopsy looking for IgA deposits. They may need a renal biopsy to see if there's IgA deposits there. Remember, intussusception is a medical emergency and they will need surgery. They may need hemodialysis if renal failure is present. You're going to give them isotonic fluids in the hospital if they're hemodynamically unstable. Fluid restriction if oliguric or anuric. Strict monitoring of vital signs, accurate measuring of daily weights, pain control with pharmacological analgesics. Do not give NSAIDs. You're going to do instead acetaminophen. Glucocorticoids therapy for those with severe pain, which is like your prednisone or your methylprednisone. You only use narcotics if severe pain is not controlled with other measures. You are going to do non-pharmacological measures such as positioning, distraction, and therapeutic play, skin care to prevent breakdown, monitor for abdominal pain, monitor for occult blood and stool, and involve that family in there. If in their plan of care, if they are hypertensive, you're going to give the nifedipine orally or sublingually, and we do give sublingual if we have to get it in them faster, because remember, when you're taking medicine by mouth, typically doesn't start working for about 45 minutes, but because under your tongue, your sublingual area is so vascular, you start seeing improvement about 20 minutes. We can also do an ACE inhibitor such as enalapril. You're going to give them their prednisone, HUS, H-U-S, hemolytic uremic syndrome. We really don't know what causes this, but we do know it has a triage of symptoms: microangiopathic, hemolytic anemia, and thrombocytopenia, and acute kidney illness after a recent disease. It's based on clinical findings and lab studies. It's most often after E. coli, but can be after strep pneumo or Shigella. Typically see it in summer and fall. They typically have bloody diarrhea, pale, oliguria or anuria, hypertension, bruising, purpura, petechiae, jaundice, edema, irritability, anorexia, seizures. You're going to do a UA to check for hematuria, proteinuria, or cellular CAS. A CBC checking for anemia, thrombocytopenia, mild leukocytosis. You'll do a peripheral smear, which looks for schistocytosis, which are helmet cells. You'll do a retic count, which is often elevated. You're going to check for lactate dehydrogenase. It's elevated because of the increased hemolysis of the blood cells. A Combs test is negative. A PT and PTT are normal. BUN is elevated. Creatinine is elevated. Electrolytes, you often see hyperkalemia, hyponatremia, hypocalcemia, and hyperphosphatemia. So remember, you got to make sure they're not having cardiac arrhythmias. Their anion gap is elevated with metabolic acidosis. They have an elevated total bilirubin. They may need hemodialysis. They may need blood transfusions. They may need anti-epileptic medications for seizure control, such as your lorazepam or your phosphophenatoin. Provide IV fluid hydration using isotonic fluid, paying very close attention to INOs. Transfuse slowly with packed red blood cells. Monitor weight strictly. Strict INOs, assess meticulously for edema or mental status changes, administer analgesics but no NSAIDs, administer antihypertensives as ordered, which is your nifedipine and enalapril. You're going to provide the family with a lot of support. These kids have a no salt added, low potassium, high calorie, high carb diet. Acute kidney injury, used to be known as acute renal failure, is a decrease in the glomerular filtration rate occurring over hours to days. The decreased renal function leads to an inability of the kidney to clear the blood of urea and regulate the fluid electrolyte balance. It's the result of poor renal perfusion or injury, and it's typically caused by ischemia, toxicity, nephropathy, or sepsis. Dehydration or volume depletion is still the most common cause. And the prognosis is dependent on the causative factor. Renal replacement therapy or dialysis is the mainstay of treatment. Hemodialysis is very what do I want to say? It works really well. Typically, these kids have a history of fluid loss, such as in vomiting, diarrhea, blood loss, or burns. They may have a history of taking nephrotoxic agents. And if you remember, that's your aminoglycosides, your IV contrast, and NSAIDs. You may see oliguria or anuria. They may have hypertension. They may have a change in their level of consciousness. They may have anemia. They may have seizures, edema. You're going to do a BUN, which shows elevated BUN, creatinine is elevated. You're going to see hyperkalemia, hyponatremia, metabolic acidosis. So again, you got to worry about the cardiac arrhythmias. CBC is going to show anemia. UA may be normal, but you can see some proteinuria and hematuria. Stool and blood cultures are done. Renal ultrasound to look at their kidneys. ECG to check for the cardiac arrhythmias. All kids need concurrent IV fluids to combat ongoing losses of acute illness. Severe dehydration or shock need rapid correction of fluid balance to restore tissue perfusion. Fluid removal with dialysis if fluid overload is present. Seizure control, and you can give lorazepam if needed, phosphophenatoin. Getting to the GU anomalies, we have cryptorchidism and hypospadias. And this is where they're born with a incorrect anatomical location. Cryptorchidism is undescended testes, and it's the most common birth disorder. If it's abdominal, it's non-palpable. If it's peeping, it's abdominal but can be pushed into the upper part of the inguinal canal. Gliding, the testes can be pushed into the scrotum but immediately retracts. Ectopic is perineal or superficial inguinal pouch. So typically there's signs and symptoms, and assessment is an asymmetrical scrotum, a small appearing scrotum, no palpable testes in scrotum. And if you find it in a newborn, you're going to refer to the pediatrician or pediatric urologist. Consider the possibility of virilization from congenital adrenal hyperplasia if it's bilateral. Typically, they're going to have an orthopexy. So you're going to do pain control, discharge education, making sure they have a follow-up appointment. You're going to educate caregivers that they need regular follow-ups with pediatrician to track the testes descent. And surgery is typically between 6 and 18 months of age. Hypospadias is where the urethral opening on the ventral surface of the penis is not where it should be. It's usually isolated anomaly. You can have the urethral meatus on the glans penis, coronal, subcoronal, mid-penile, penoscrotal, scrotal, or perianal area. It can be anywhere. Typically has a ventral curvature of the penis, a hooded foreskin, and they may have undescended testes. They can also have an inguinal hernia. Newborn males with hypospadias. Last question. What is the most common cause of acute kidney injury in peds? Ischemia, massive proteinuria, E. coli, or volume depletion? Volume depletion, most common cause of acute kidney injury. So that is it. I'm glad that this was shorter than the last one because I know you guys have a lot on your plate. If you have any questions, don't hesitate to let me know. Thanks.